covering about the latest GINA guidelines which came in 2025 on asthma management. See you soon. All the viewers of HCM, I am Dr. Asmitha and I have covered part 1 and part 2 of asthma modules, and we have reached up to asthma diagnosis and asthma prevention. In part 3, I am going to talk to you about asthma management as per international guidelines, GINA, or Global Initiative for Asthma Management. That is what the full form is. Every year, for last few years I am seeing it comes every year about how to advance management of asthma as progress. And drugs used for the management of asthma, stepwise management of asthma, what is new in GINA and your approach for management. That is what my specific learning objective. So there are components of asthma management. One is education. Educate your patient what not to do, what to do, how to use inhaler, how not to miss the medicines, etc., etc. You can have educator nurse if you have busy clinic like me. I have got separate people to teach them how to use inhaler, and I have got a social worker who deal with all this teaching part. So as per your practice busyness, you can decide. Then you have to do monitoring, which I do every quarterly. We do a PFT test. Before stepping up or stepping down, you should do repeat spirometry. Pharmacology, treatment plan and follow-up. So the asthma treatment is divided into two parts. One is relievers and one is controllers. Now earlier people used to use only relievers, that is beta-2 agonist, salbutamol. And earlier patient used to use only relievers because they were thinking that when they take those relievers, it gives immediately relief. Actually, you have to tell them that it is like a paracetamol. If you have got a headache, you take paracetamol. But if you have daily headache, you have to find the reason and treat the cause. Just the same way, if you will use the reliever medicines, it will give you immediate bronchodilator effect. But the effect will last maximum 20 minutes to 2 hours. It has nothing to do with the primary problem, which is inflammatory problem. As I told in the definition, asthma is a chronic inflammatory disease. So until unless you will have addressed that particular issue, it will keep coming back. So you have to explain that. And for overcoming that particular problem, GINA has come up with new plan, which I will come into that. So first and foremost, treat rhinitis. If patient has got sneezing or running nose, you please treat with nasal steroids or nasal ipratropium or nasal antihistamine or proton pump inhibitors if patient has got GERD. Air purifiers and molds cleaning, yes, it has got role, but I would not put in the top of my list of treatment. Now sympathomimetic drugs, which is beta-2 agonist, short-acting salbutamol, tolbutal, palmitrol. Even the market, it is very difficult to get those tablets, but it's still there. And long-acting like salmeterol, formoterol, which was commonly used, has been replaced by ultra-long-acting indacaterol. Now, side effects of all this, any beta-2 agonist in general, if the newer one has got lesser side effect, at least that is what pharma companies claim. So, muscle tremors are less. Hypokalemia is one of the side effects. Remember that. Jitni happens, they will come and tell my finger becomes tight. Mostly, if you correct their calcium level, they will be fine. Muscle cramps, tachycardia, tachyphylaxis. All these are observed. I have seen all this side effect. Now, these are the anticholinergics which we use. We used to use ipratropium, oxytropium. I have never used. LAMA or long-acting muscarinic agents, which are tiotropium. Nowadays, we use less tiotropium and more glycopyrrolate. That is what is the newer muscarinic agent or anticholinergics. And sometimes you might develop dry mouth or unpleasant taste or glaucoma because of anticholinergic side effects. Now, methylxanthines or delphyline, it is still used. I also use it. Mechanism of action, release of calcium from sarcoplasmic reticula, phosphodiesterase inhibit, and adenosine receptor blockade. These are the three main actions. The side effect profile is plenty, and I won't go into detail of that. You can find that out. The other commonly used is leukotriene receptor antagonist, that is montelukast and zafilukast. The commonly used is montelukast. It has got a leukotriene receptor inhibition, which is one of the pathways for causing asthma. Now, steroids are the mainstay of treatment for exacerbation. Inhaled steroids are the stay of treatment for control of asthma, because asthma is inflammatory disease. So it works as an anti-inflammatory effect, and if you have got good use of steroids, you can decrease the relieving medication by controlling the inflammation. This is not a converter. This is how low dose, medium dose and high dose is divided. As you can see, fluticasone furoate is the strongest or most potent steroid, which needs only 100 microgram and 200, while you can go for fluticasone around 500. You can go budesonide to 800. These are the high dose and low dose of inhaler. Steroid also is most commonly used drug, and I will cover its side effects because those are important. You have to teach your patient how to use it, otherwise they will come with oral thrush. Myopathy or muscle weakness happens, particularly vocal cord myopathy, which will cause change of voice. And especially those singers or teachers who are having asthma, if your patient develops myopathy, it is irreversible. So you have to be very careful. If you are using MDI, you have to use it with spacer. You have to tell your patient that after taking inhaler, please rinse your mouth. That particular, even though my educator teaches them how to use inhaler, I spend my time in the first visit and tell them that after every puff, after every dose, like 2 puffs you are taking, after those 2 puffs are over, just rinse the mouth so that accessory medicine which is remaining in the mouth will get washed off. Hyperglycemia on chronic use, 10 to 20 years, yes, it can cause hyperglycemia, though it is not like diabetes, but yes, it can cause. Cushingoid features for oral, osteoporosis for oral, and chronic use of steroids can cause osteoporosis in old age, cataracts for oral corticosteroids. Now these are the medicines which I already told you, and reliever medications are SABA and LABA, and we have got rapidly acting beta-2 agonist, which can be used as a reliever as well as controller. So those are the advancement which has come. Now moving on to GINA 2025 personalized treatment plan. What we do is we review the patient's symptoms, we review how frequently they have exacerbation, we review their comorbidities, we find out what is their lung function, and we grade mild, moderate and severe. We consider biomarkers like IgE and eosinophil for streamlining our treatment, and then patient and caregiver satisfaction. That is review. Now assess confirmation of diagnosis, rule out other all mimics. Symptoms and modifiable risk factor has to be addressed. Find out any other comorbidities like obesity, GERD, sinusitis, rhinosinusitis, or heart failure. And patient preferences and goals should be addressed. Now, adjust as per the need, treatment modifiable risk factor, non-pharmacological strategies like avoidance of triggers, weight loss, asthma medication including ICS, education and skills and training. Now, any treatment you divide or decide, it is depending on the efficacy, effectiveness, safety and access. So how do you do? So preferred medication you have identified. After that, you have to see the patient characteristics and phenotypes. Does the patient have any factors that predict the differences in the risk of treatment like smoking or SABA overuse or exacerbation? History, high phenol or eosinophils can be taken care of. And then patient views are very important. Practical issues for the preferred medications like which inhalers. There are different type of inhalers. Some patients prefer MDI, some patients want Rotacaps. So depending on that, some patients are already using that. There is no point of changing until unless, like nowadays only DPI inhalers are available for high level medicine. So then we have to convince the patient that we do not have any choice. Otherwise, mostly what I do is I don't change the type of inhaler just for the heck of it. Please make the patient comfortable, ask them which device they will use it, and if you have time, see how they are using. And then can they afford the medication, because all these medicines are actually expensive. Adherence is something you can ask how many devices they used in last 1 month. So all doses are calculated 120 MDI, 120 puff per MDI. So if patient is using regularly, mostly they will need 1 device per month, and that's how you can check adherence in our world. Now, shared decision making, which is like you make a patient part of the decision, and that's very uncommon in India, but it is changing, and I'm very happy about it. So you have to ask that which medications they are comfortable, which of this inhaler has the lowest environmental effect, follow up the patient satisfaction each visit, and for those medications currently the patient is, are they happy? Now, GINA goal of asthma management is treatment goals should be personalized and achievable, which I already told you about what exactly is the treatment goal. So we want basically the not only control, we are going for remission of asthma, just like any cancer diseases. We have achieved asthma control or even cure. So remission from childhood wheezing or asthma, remission in adults, and beware of encouraging inappropriate step-up of therapy, which can happen because of obesity or any other comorbidities. Now, how do you assess asthma? I have covered it, but if you want, we can just go through it one more time. I told 4 symptoms: daytime asthma, any night awakening, any need of SABA, or any activity limitations. Well controlled, none of this. 1 or 2 of this is partly controlled, 3 or 4 uncontrolled. So first and foremost, first time when the patient is coming, you have to find this. If patient is on medicine, this is how you will assess. Now, risk factors for poor control. Check the compliance, check the technique. Now, whether they are using the inhaler properly. So, SABA overuse was one of the main problem which was happening earlier. So, that is how they came that we do not have to give SABA to our patients. So, let us cover that. So, that particular thing came first time in GINA 2019 when they told fundamental change in asthma management. Till then, salbutamol was coming as a first-line treatment as a reliever. While in 2019, GINA came in an editorial that treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. And that is how this track 1 and track 2 came. Now, those of you who are not aware of what is track 1, in track 1, the preferred controller and reliever are formoterol ICS combination as needed. While track 2, the reliever is only SABA. Now, here they have put a box warning that you are starting your patient on track 2. Be sure that their compliance is very good and they will use each time when they are using their SABA inhaler, they will use their controller medication also. If you are explaining that, then only you can go to track 2. Otherwise, you go for track 1. Track 1, so step 1 and step 2 is combined. Step 1 and step 2 is AIR. So it is only anti-inflammatory reliever. Why it is called anti-inflammatory reliever? Earlier it was a bronchodilator reliever. Now we are adding steroids to it. So that is called AIR. AIR is low dose ICS formoterol as needed. That is step 1 and step 2 is enough. Mild to moderate asthma, that is enough. If your patient has got less than 80 to 60, even if you do that, that's fine. Between 80 to 60, you have to do SMART or MART approach, that is maintenance and reliever therapy same, which is low dose maintenance ICS formoterol. Patient has to use that. Now, in between, if there is any spore of symptoms, you have to give reliever as needed, the same inhaler. Now, up to 60% you can give low dose. 60 to 40 or less than 40, you have to hike up to medium dose maintenance. And step 5 is one thing which I would not suggest that you follow anybody's advice, that has to go to specialist center. Up to level 4 or step 4 you can manage. Now step 1 in step 2 is reliever only SABA, but they have to take ICS separately every time they use their SABA. Step 2 is low dose maintenance ICS alone. So here we are using formoterol and steroid combination. Here why formoterol? Because it is fast acting as well as long acting. While in step 2 low dose ICS. So here 1 and 2 are different. Here 1 and 2 are same. Now step 3 is low dose. Now step 3, step 4 and step 5 in track 1 and track 2 are same. So the only treatment of track 1 and track 2 changes was we added AIR. What is AIR? So AIR or anti-inflammatory reliever only, AIR only and MART. That is what. So here it is AIR only, here it is MART. So why this anti-inflammatory reliever came in picture? Because when we were giving them two inhaler, one blue inhaler, one red inhaler, what used to happen is they used to do regular use of reliever, because obviously when some medicine is giving you immediate relief and some medicine takes years to come response, you obviously will take the medicine which gives you relief because you feel that is good medicine, and that is what patient used to do, and that is what was causing more mortality, and I will show you the data for that. So regular use of SABA even for 1 to 2 weeks is associated with significant adverse effect. It causes beta receptor down regulation. The same response does not come, so patient tend to increase the dose, which will cause the more side effect and less effect. Decreased bronchoprotection, rebound hyperresponsiveness, and decreased bronchodilator responsiveness. That is what happens. Increased allergic reaction also used to happen. Now this is one diagram which I wanted you people to see. One second. Yeah. So this is how SABA reduces the consequence. So you see here the symptom, then 1, then 2, then 3, then 4. So actually there is no improvement, but they just increase from 1 or 2 puffs to 100 puffs or 10 puffs per day, and by the time they go for the medical care, it was too much delayed, which was causing more problems and more severity of the patient. And then their lung function used to come deep when this particular dose was increasing, and that was making more difficult for doctors to manage. Now you understand that if your patient is using like this, what will happen? So SABA reduces the consequences but not the cause of exacerbation. So finally they will come in a very, very bad shape. So that was the cause of increased mortality of asthma in countries like India. So what they found out is more than 3 canisters per year, it causes increased risk of exacerbation. More than 12 canisters in a year, increased risk of asthma related death. And regular use of SABA increased allergic responses and airway inflammation. Actually, it caused asthma. So that is why the evidence came that if you are using MART approach, there is a less than by 32% less exacerbation, by 23% it causes less severe exacerbation, and 17% with conventional best practice. So if you use MART approach, it is the best for controlling of asthma, and there are enough data for that. I use track 1 approach. I do not give SABA treatment anymore to my patient. Actually, I never used to give. This guideline came in 2019, but we never used to give even before that because we know the consequences. An example of GINA track 1, this is what you should be doing. Track 1 is preferred treatment. Use ICS formoterol as an anti-inflammatory, or AIR as well as MART with or without maintenance ICS formoterol. You can use it as a maintenance as well as reliever both. When it comes to high dose ICS LABA, that is the ceiling. After that, if your patient is not improving, it is better to refer them to a specialist center which deal with that. Now track 2, when you are using track 2 as where we are using controller and reliever separately, that is where you have to know, you have to check before considering this regimen that if patient is likely to adhere to use daily ICS as well as and when required treatment is used, additional ICS has to be used. If you are able to make them do that, go with this regimen. This particular thing I have already covered and I will move. So this is how track 1 and track 2, the change is in the step 1 and step 2 only. Step 3, step 4 is almost same, and that is how you have to see the daily symptoms, waking at night, limitation of activity, and SABA use. If that is there, medium dose ICS formoterol, medium dose ICS formoterol, as SABA is changed. Then low dose, you can step down or step up, or step up, step down, according to the control of the symptoms. Now we will move on to the delivery part. So how you decide the inhaler. I believe there will be one separate class about the inhalers and all. I am just giving one slide about how does it affect, how do you decide which inhaler. It is on the age of the patient, socio-economic condition, disease condition, personal acceptance and training. Then there are some devices which gets more delivery or better delivery at the smaller airway. So you have to decide on the severity, design, consistent doses, ease of use and cost, formulation, stability and safety. Don't forget that. Okay, that's all for the asthma management. Thank you so much. And in the next